Hello there, my name's Nivian. I'm a recently graduated final year medical student from Barts. So today I'm going to be going through topics under the Brain and Behaviour module of Year 4, specifically things to do with neuro as well as neurosurgery. The things I'll be covering in today's presentation include head injury, subarachnoid hemorrhages, central nervous system infections, as well as cerebrovascular disease, namely strokes and TIAs. The sources I've used for this presentation include the Central Teaching Lectures, the Oxford Handbook of Clinical Medicine, as well as PassMed. And here are the learning objectives, basically what I've gone through. But just briefly, we're going to be going through TBI, the different types, going through the GCS scale, some nice guidance on when to do CT heads, and also going through the Munro-Kelly hypothesis and the various types of hemorrhages. Then subarachnoid hemorrhage, basically going through a disease profile, a few infections under the central nervous system, and then strokes and TIAs. So to start with, head injury or traumatic brain injury. So how you can classify it. So the major one used are the three ones listed here. So they can be graded by severity, so the GCS scale, Glasgow Coma scale, by mechanism, so is it a blunt trauma, is it penetrating trauma, and by pattern as well. Okay. Moving on to the GCS scale, so there's quite a apt acronym for the GCS scale. It's MOVE, so M-O for motor, V for verbal, E for eye-opening, and it follows the numbers of 6, 5 and 4. So let's start off with the motor. So 6 obeying commands, 5 localizing to pain, 4 withdrawing from pain. So say for instance the difference between 5 and 4. So if you do for number 5, if you do a trapezius pinch, it's known as localizing to pain if the patient's arm comes above the clavicle, and then that would indicate localizing to pain. For the grade of 4 under the motor, withdrawing from pain, say if you press on the nail bed of someone's fingernail and they move away from you, so they fling their arm away, that would be graded as number 4. Number 3 is the decorticate positioning, so that's the first image here. So the arms are sort of flexed onto the chest, the feet are plantar flexed, slightly internally rotated. And then number 2 is decerebrate positioning, which has a worse prognosis compared to decorticate positioning. Here the arms are extended and pronated either side of the patient's trunk, and then grade 1 for unresponsive. So there's 6 grades for motor, 5 for verbal, so orientated, confused, inappropriate words, incomprehensible sounds, and then no response. And finally, for eye-opening, it's very much like AVPU. So if you count 4 points for the A, so alert, so i.e. spontaneous, then to speech or verbal here, so that's 3 points, to pain, which is 2 points, that's there, and U for unresponsive, which is none. So you can, if you're having difficulties remembering that, you can just use AVPU for the I bit. So just to summarize, for GCS, it's important you know this, just for motor there's 6 grades, verbal 5, eye-opening 4. Great. So, primary traumatic brain injury. So this is primary because it happens at the point of impact. Or if it were to be non-traumatic injury, it could be something like hemorrhage or ischemia. And primary brain injury continues over hours to days, and it eventually leads to axonal retraction as well as neuronal death and apoptosis. After the traumatic brain injury, the brain has some potential to change, to evolve. The axons separate, they form retraction balls. This often takes a couple of days, and then they begin to separate. You find globular proteins and microfilaments, which the axons initially had, leaking out of them, and this is what's known as the retraction balls. As I mentioned earlier, the neurons then undergo cell death. They lose their energy and ion metabolism, leading to cytotoxic edema. The problem is, with traumatic brain injury, repair of the brain is extremely difficult. The brain doesn't really have much mechanisms for generating brand new axons, neurons, etc. So that's why it's difficult if someone were to have a brain injury. And currently we don't have that many, if any, actually, therapeutic interventions, treatments, etc. that would change this. And it's seen as a more of a clean-up process rather than laying down any new foundations. So the bottom line is, if someone's got brain damage, it's likely to persist. Secondary traumatic brain injury, as the name suggests, would occur after the primary stage, and this is something we definitely can prevent. Okay, it has the same sort of dire consequences in the patient. It's just as irreversible as primary, but it's things that we can hopefully prevent. So hypoxia, systemic hypotension, intracranial hypertension, these are things that we can potentially look into. And the reason why the primary traumatic brain injury is likely to progress to secondary is because the damaged brain tissue is even more sort of susceptible to threat and insult from these aforementioned mechanisms. Okay, so it's best that we start medical intervention early to prevent this from happening. So the pathophysiology of traumatic brain injury is as follows. So I've mentioned earlier, in terms of one of the classification types, it can be classified as focal or diffuse, depending on focal just being a small area, diffuse as in the entirety of the brain. In the diffuse picture, a diffuse axonal injury can occur as a result of mechanical shearing or tearing following a deceleration injury, and this can basically rip up the axons. Intracranial bleeds and hematomas can take many forms, some of which include extradural, subdurals, or intracerebrals, while contusions can occur at the site, which would be a coup, or a contracoup, which would be contralateral to the site of impact. Secondary brain injury can occur, as I've mentioned, because of edema, ischemia, infection, as well as brain herniation, which I'll come on to later on during these slides. And I'll just introduce this concept now, but you'll see it later. The Cushing's reflex is quite a poor prognostic indicator. It's likely to indicate poor prognosis because this indicates that there's brainstem compression due to tonsillar herniation of the brain, and it can cause compression of the cardiorespiratory centers of the brainstem, causing hypertension, bradycardia, as well as an irregular respiratory rate. So that's the triad, but as I said, we'll come on to it later. So, before we go on to how we prevent secondary brain injury, I'd just like to refresh your memory on resuscitation, because this is basically the ultimate priority. We need to get this in order before we think about anything fancy. So that's your standard A to E management, which was introduced to you back in year 3. So making sure you get oxygenated blood to the brain, considering C-spine immobilization if we're thinking about someone having a C-spine injury, airway maneuvers and how that influences your C-spine management, and also treating other injuries, such as if someone's bleeding profusely and may need ICU support if it's out of your competence. So, investigations that ought to be ordered may include a CT head, may also be coupled with a C-spine as well, and even chest, abdomen, pelvis to have a look for any contusions there. And do your basic investigations, bloods and thorough examination, history if possible. So, this is quite important. So, it's not, when we order investigations, whether that be from an X-ray, CT head, bloods, etc., there needs to be a reason why. We need to justify whether this particular patient needs this imaging. And NICE has produced quite clear guidelines as to when we need to perform CT head on someone. And that can be for immediate CT head, or those within 8 hours of injury. So those which would need an immediate CT head are listed below. So they include GCS below 13 when the patient presents to you, or less than 15 2 hours post-injury. You've got a suspected skull fracture, any sign of basal skull fracture, so things like panda eyes, rhinorrhea, battle sign, which is bruising behind the mastoid, post-traumatic seizure, a neurological deficit, such as arm and leg weakness, etc., or 1+ episode of vomiting. Those that require CT head within 8 hours are adults with any of the following risk factors who've experienced loss of consciousness or loss of memory post-injury. So those who are 65 years old and above, those with a history of bleeding or clotting disorders, if it was a dangerous mechanism of injury, so falling down 5 stairs or some kind of accident, or if the patient's got more than half an hour worth of retrograde amnesia. These criteria would fulfill, one of these anyway, would fulfill criteria for someone getting a CT head within 8 hours. So, things to consider. So, CT scans, we've mentioned. The likelihood is you'd want to refer to the neurosurgeons if they can do something about it, operate on the patient with a craniotomy. ITU would be thinking about the intracranial pressure, because an increase in intracranial pressure is a bad thing. Craniectomy, the logic behind this is to do with the Munro-Kelly Doctrine, which I'll come on to later. Just so you're aware, with regards to CO2 and intracranial pressure, CO2 causes vasodilatation of vessels. So, if someone is hypoventilating, in other words, they're retaining a lot of CO2 because they're not blowing it off, this would cause the blood vessels to dilate and increase the intracranial pressure, which in these circumstances is bad. And on the flip side of that, those who are hyperventilating, i.e. blowing off loads of CO2, would cause a vasoconstriction slightly to the vessels, decreasing intracranial pressure. So this may benefit someone who has an increased intracranial pressure, but you don't want to overdo it because it could lead to ischemia due to vessel constriction. Sedation. So sedation is something that is considered because you're basically reducing the metabolic demand that the brain is requiring. So it needs less oxygen, etc., glucose, etc. And finally, rehabilitation. So, decompression. So we need to think basically when we come to decompression about what's within the skull. So crudely speaking, that's blood, cerebrospinal fluid, the brain, which encompasses around 95% of that volume, and then a mass. So the mass could be blood, it could well be a brain tumor, could be an abscess, any of these things that really shouldn't be there. Fine. So basically it's what I've been, this is the Munro-Kelly Doctrine. So this is the normal state. So within that you've got brain, although I said it's 95% occupancy of the box being the skull. It's not really demonstrated on this diagram, but hey, so you've got the brain, you've got blood in terms of venous and arterial circulations, and you've got the CSF. So when someone's ICP, intracranial pressure, is there's a threat of it being increased because of a new inclusion into this box. So in this case it's the mass, which as I said could be abscess, tumour, hematoma, etc. You can compensate for it by a leakage of the venous blood as well as the CSF. If, however, you've exhausted this, and that's the compensated phase, if you've exhausted this mechanism, i.e. you've basically got rid of as much venous volume as you could and as much CSF as you could, and you don't really have any much room for manipulation, then it becomes decompensated, and that's when the ICP starts to shoot up and we come into problems. So I've just written down basically what I've said, but the skull is a box, it can't expand, so you've got the brain, CSF and the blood. Your intracranial pressure is going to increase if you've got a sudden sort of mass or any other occupancy within that box. And initially the venous blood and the CSF can compensate for it. Afterwards, the brain tissue eventually herniates, and that can lead to coma and death. So that's why it's important to get on this quickly. And here I've listed the various causes of the masses that we saw in the previous diagram. There. So, just a little bit more about the Munro-Kelly Doctrine. So here I'm talking about the decompensated phase at the top here. So, in other words, when you've got rid of the venous blood and the CSF, you don't have much room for error, at which point the brain tissue or penumbra starts to suffer. An equation to be aware of is the cerebral perfusion pressure is equal to the difference between the mean arterial pressure and the intracranial pressure. So if you just look at this quite simple equation, if you were to get an increase of this number, okay, that's going to lead to a decrease in your CPP, isn't it? Which is obviously bad. And CPP is a cerebral perfusion pressure. In other words, the blood that is going into the brain is going to reduce as a result of higher ICP. So that's pretty much it for Munro-Kelly. So I'll take us back to traumatic brain injury. So back to decompression. So basically, if you base it on Munro-Kelly itself, the ways in which we can accommodate for a mass are blood, CSF, the brain tissue, or just basically opening up the box, giving us more room. Box being obviously the skull. So how we can manipulate this? So blood. You got venous, arterial. So how we can manipulate the venous blood? Loosen the neckties, collars, keeping the head up would allow more drainage. Or with arterial blood, sedating someone, and maybe hyperventilation because of the lack of CO2 causes a vasoconstriction of the arteries. With regards to CSF, we can put in a drain, direct the CSF elsewhere, and it's often used in pathologies such as hydrocephalus. If it's a mass, masses can take the form of hematomas, extradurals, subdurals, etc. Basically try and evacuate them, get rid of them. And finally with the brain, not really much we can do really with the brain apart from reducing edema and swelling. So we can use something called mannitol, which is a type of sugar, and it basically draws out fluid from the brain, again reducing the edema. Lobectomy, removal of a particular lobe, used to be done, but it's pretty drastic, it doesn't tend to be used nowadays. And finally opening the box, a craniectomy, basically to increase the available volume for the brain. So here I'm just summarising now the stuff we've gone over in traumatic brain injury. So if someone's got life-threatening intracranial pressure increase, may have an extradural, etc., and you're transferring them to theatre, we may want to consider things like mannitol, furosemide. Again, that's targeting the brain edema, the fluid there. We are not using burr holes nowadays in modern practice. We're only using them if scanning is unavailable, so CTs, etc. It's quite uncommon here. We obviously have good access to facilities, etc. In terms of intracranial pressure monitoring, you want to be doing those in those who have a GCS between 3 to 8 and an abnormal CT scan. Bearing in mind anyone with a GCS below 8 is likely to need airway management from anaesthetics point of view. Definitely would need a neurosurgery referral. Hyponatremia is a potential complication. It's often due to the syndrome of inappropriate antidiuretic hormone release. And we need to maintain that cerebral perfusion pressure. Just keep in mind the equation CPP equals MAP minus ICP. The long-term sequelae of a traumatic brain injury. So someone may develop disability, neurological disability to be precise, which may require rehab of some sort. Epilepsy, hydrocephalus, which is basically an accumulation of CSF within the ventricular systems of the brain. Patient may even go into coma. And then this last point here, just so I could cover that, is to do with basal skull fractures and NG tubes. The reason why I bring this up is because it's very important, because there are quite a few contraindications to putting an NG tube in someone. So they may include, someone having a recent nosebleed, esophageal varices, but a very important one is someone with a basal skull fracture. So some of the signs you may see from there include these panda eyes, which is basically a collection of blood. Battle sign, which is the mastoid bruising. You may see CSF leaking from the nose as well as the ears. So it's just careful to bear that in mind, because if you stick an NG tube in someone like this, its likelihood is just going to puncture the brain, and that's obviously not good. Now moving on to brain herniation. Okay, so this is basically part of the decompensated phase of the Munro-Kelly Doctrine. When you've used the venous blood and the CSF, don't have much left to push out really, at which point the brain starts to come out, and they're displaced. And it can cause compression of important structures. So we touched upon Cushing's triad, and that can be as a result of coning, and it's a really bad sign and is a neurosurgical emergency and requires intervention of some sort. So coning in a bit more detail. So once we've come to this decompensated stage, and as the ICP increases rapidly, the sort of base of the brain starts to work its way through the foramen magnum and compress upon the cardiorespiratory centres of the medulla oblongata, and that leads to the Cushing's triad of bradycardia, hypertension, and an irregular respiratory rate. Okay. In terms of classifying herniations of the brain matter, there's various types. So the first one I'd like to cover is subfalcine, which is basically when the brain herniates underneath the falx cerebri, which is basically like a collagenous sort of sheath dividing the right and left hemispheres. And also when we have a subfalcine herniation, there may even be compression of the anterior cerebral artery and its branches, so it can cause a stroke with weakness of the lower extremities, the legs. We can have central herniation, which is basically downward displacement of the brain, or transcalvarial, where the brain is displaced through a defect in the skull, perhaps through a fracture or craniotomy site. The other ones to be aware of include a transtentorial, or otherwise known as an uncal herniation, where a bit of the temporal lobe starts to move underneath the tentorium cerebelli, and can cause pupillary abnormalities due to cranial nerve 3 or oculomotor nerve compression. Tonsillar herniation is basically the coning which we covered, so where the cerebellar tonsils work their way through the foramen magnum to compress upon the cardiorespiratory centre. And this is often seen in a condition known as Chiari-1 malformation as well. Fine. And finally, just something that was in the lectures that you may not have been aware of. Durette hemorrhages, or Durette hemorrhages, are areas of sort of bleeding points within the midbrain and the upper pons, and they're caused by traumatic downward displacement of the brainstem tissue. And here's just a diagram basically demonstrating the herniation types. So we've got the subfalcine, where the brain matter is working its way under the falx cerebri, compression of ACA artery. We've got tentorial herniation, thinking about cranial nerve 3 here, with the temporal lobe working its way under the tentorium cerebelli, and then you've got the tonsillar herniation, which we've talked about extensively with regards to coning and Cushing's triad, etc. I've just listed a table here from PassMed which goes into the various pupillary findings in head injuries, and you can look at that in your own time. And now I'm just going to move on to intracranial hemorrhages. Okay, so the ones I'm going to be covering are extradurals, subdurals, subarachnoid, which I'll cover in a separate bit of the presentation, intracerebral hematoma, and intraventricular hemorrhages. So let's go for that then. So extradural hemorrhages. So this is what it's likely to look like on a CT scan. Okay, so what you can see is, first of all, this is the right, this is the left. You can see the bleed forms a sort of lens-like shape, or often known as a lentiform or lenticular shape, and it does not cross suture lines. It's very well contained, and it's quite hyperdense, it's quite bright here. Same sort of thing here as well. Okay, so extradural hemorrhages. So extradural means outside of the dura. Okay, so thinking about the layers of the meninges, you've got the DAP, or the dura arachnoid ampia. So this is outside the dura, the topmost bit of the meninges, outside of that. So it's the extradurals happen in between the space between the dura and the skull. Okay, and often results as because of acceleration or deceleration or a blow to the side of the head. Often can be caused by laceration of the middle meningeal artery, which comes through the skull by the foramen spinosum. You may also see bleeds in the parietal bone region. Just briefly on the middle meningeal artery, it goes behind the pterion, which is quite a weak part of the skull. Okay, so some of the features they may present with: increased ICP, so we've covered that already. They may exhibit a lucid interval. So what that means is they seem fine, essentially. So the typical picture is someone gets a blow to the head. They may lose consciousness for a bit. They may seem confused. They come back. They seem fine, and then go back into a decline in consciousness. So a lucid interval can often trip you up, and you may think the patient is fine, where in actual fact that's very much not the case. And with regards to herniation, which may occur in extradural hemorrhages, you may find an uncal herniation with cranial nerve 3 compression. Just a little bit more about extradural. So this lucid interval, which I mentioned, can last between hours and days. Symptoms they may present with include a headache, vomiting, they may be confused, they may be fitting, may have weakness, and it may suggest an upper motor neuron lesion. As bleeding continues, not only do you get uncal herniation, you may even get coning, respiratory arrest, and coma. We've talked briefly about the CT image and what that shows. It's that lenticular shaped hematoma. Due to the tough dural attachments, it doesn't cross suture lines. So you'd always want to do a CT head on this patient, in these kind of patients, with the history of quite severe trauma. And of course, because of this bleed, the likelihood is the intracranial pressure is going to be increased, so therefore you would not do an LP or lumbar puncture in this case, because it is contraindicated for anyone with an increased intracranial pressure. Management of this is with craniotomy and basically getting rid of the hematoma, stabilizing them prior to doing this, and make sure to take them to a neurosurgical unit, making sure airway is patent, and thinking about mannitol use to reduce the edema in the brain. Prognosis is actually very good if you diagnose and treat early. But if you're starting to get other neurological features like coma, pupil changes, and decerebrate rigidity preoperatively, then prognosis is quite poor. Now, moving on to subdurals. So subdurals will be underneath the dura layer, so in between the dura and the arachnoid where you have those bridging veins, and that causes a more sort of crescent-like shape to the bleed, which does cross suture lines. It's not as tightly confound as extradurals. This is, the right-hand side picture shows an acute subdural with a hyper-dense lesion, and this would be the one on the picture on the left would be a chronic subdural hemorrhage with a hypodense bleed, as you can see on these CT scans. So an acute subdural is a fresh collection of blood underneath the dura, between the dura arachnoid layers, can be caused by trauma or AV malformations. Risk factors can be high alcohol consumption, old age, due to brain atrophy and anticoagulant use, such as warfarin. Etiology behind it could be high-speed injuries, acceleration, deceleration, much like extradurals actually, and so there may be other brain injuries to look out for. Those bridging veins that I mentioned that are collecting blood between the cortex and venous sinuses, they may bleed, so this results in increased intracranial pressure, shifting the midline structures away from that side to the contralateral side. There's a shift towards that, and then that can lead to brain herniation, whether that be tentorial or tonsillar. And symptoms include a fluctuating level of consciousness, which is classic of subdurals. There may be intellectual decline. Patient may feel more drowsy. They may have a headache. Personality may change. They may be wobbly and unsteady on their feet. Signs to look out for may include signs of increasing intracranial pressure, fitting, neurological deficits, whether that be pupillary or weakness, and the clinical presentation of subdurals can be very largely variable, from those who are asymptomatic to those who are very severely comatose. And we've touched on the CT imaging findings already. The treatment for this is a decompressive craniectomy or a burr twist drill with burr hole craniostomy. For that, craniotomy would be a second-line procedure. Chronic subdural hemorrhages, so pretty much the same sort of risk factors as an acute subdural, alcohol consumption, elderly patients, anticoagulants, etc. But the history is of someone who's had some kind of minor trauma but forgot about it, and presents weeks to months after that with, headache, confusion, reduced consciousness, weakness, etc. CT imaging will, in this instance, show a hypodense, sort of a dark crescent-like collection of blood that crosses suture lines, and you need to do a burr hole drainage to treat them. Right, next, moving on, is the intracerebral hematomas. Okay, this is a collection of blood within the substance of the brain. Causes of which include high blood pressure, vascular lesions, such as aneurysm or AV malformations, tumours or infarcts. Okay, so people with infarcts, why that's important is because post-thrombolysis for strokes, which we'll go on to in a little bit, this may result in a hematoma. So that's why if you are giving someone thrombolysis, it's important to do a CT head 24 hours after you give them 12 to 24 hours after you give them thrombolysis, just to make sure there isn't a hematoma being formed in someone with an ischemic stroke. Then in terms of CT, you'll see a bright lesion within the brain substance. Treatment tends to be under the care of the stroke team. It tends to be conservative, but those with large clots may need surgical intervention. Intraventricular hemorrhages, so you may have seen this in your PEDS module, so it often happens in neonates, after birth, and it's often due to the prematurity of the periventricular vascular structures, and it's a collection of blood within the ventricular system. May occur in adults as well, isn't really as common though. So on CT you can see hyperdensity within the CSF spaces in the ventricles, and they are at risk of obstructive hydrocephalus there. So in neonatal practice, you see intraventricular hemorrhages within the first 3 days of birth, often due to birth trauma. Fine. So that's it for traumatic brain injury. The next one we're going to move on to is subarachnoid hemorrhages. Fine. So just to have a brief look at this image. So this is indeed a subarachnoid hemorrhage, as the left-hand side says. So the blood is, you can see, are within the basal cisterns, sylvian fissures. Your temporal horns are quite big here, and you can see some blood within the ventricle here. Okay, so this sort of star shape can be seen in quite a few subarachnoid hemorrhages actually. Right, so an introduction into subarach hemorrhages, okay? So a subarach hemorrhage is an intracranial hemorrhage, and it's presence of blood within the subarachnoid space. So you've got those layers, the dura, arachnoid and pia. So this is between the arachnoid and the pia, so the pia being the really thin sheath attached to the brain tissue itself. Okay, so between the arachnoid and the pia is where you get this bleed. Most common cause is traumatic. However, in the absence of trauma, it's spontaneous subarachnoid hemorrhage, which is what we're going to focus on today. And it can often be a catastrophic diagnosis with quite a big mortality. So causes of it, so as I said, trauma is the main cause, but for those which are spontaneous, it can be due to an intracranial aneurysm. So, there are 3 types of aneurysms: saccular, fusiform and berry, and in the brain it tends to be berry aneurysms. There are conditions associated with subarach hemorrhages, like adult polycystic kidney disease, which is an autosomal dominant condition. You've got the collagen-related diseases, Marfan's, Ehlers-Danlos, and aortic coarctation as well. Causes may also include AV malformations, splitting of the arterial walls, mycotic aneurysms in things like SBE or subacute bacterial endocarditis. So yeah, those are the main causes. Risk factors, so they include those who smoke, older people, those who use alcohol, misuse alcohol, high blood pressure, those are more prone to bleed, mycotic aneurysms, which I've mentioned earlier. Subarachs actually tend to be more common in females, and there tends to be sort of a risk associated with those with relatives who've had subarachs as well. Just briefly on berry aneurysms. So what an aneurysm is basically a dilatation of the walls of a blood vessel, and it's often due to a problem with the tunica media. Aneurysms are quite common in the brain because the lamina is much thinner. The brain blood vessels float within the cerebrospinal fluid. Each flow of blood in systole gives more pressure on blood vessels, especially during bifurcation. The most common site is the junction of the posterior communicating artery with the internal carotid artery. That's the most common area. Second most is the junction of the anterior communicating with the anterior cerebral artery, and then also the bifurcation of the middle cerebral. So symptoms someone may present with. So it's classically known as a thunderclap occipital headache. Thunderclap meaning it's quite severe, very, very severe, sudden onset. Never had it before, worst headache in my life sort of thing. Maybe nausea, vomiting, collapse, signs of meningism. They may display reduced consciousness, may have seizures. Catastrophically, some of them may have just sudden death. Something to bear in mind is the sentinel headaches, okay? So it's like a ticking time bomb. So someone, say for instance, has had recurring headaches over a while, you don't think it falls under the normal primary headaches of, tension, migraine, cluster headaches, etc. You need to bear in mind that it may actually be a sentinel headache, which is basically small leaks from aneurysms, and this could eventually lead to subarachs if you're not thinking about it. Okay. So signs to look out for: neck stiffness, meningism I've already mentioned, Koenig sign, and this is elicited by basically flexing the hip and knee, extending the knee, and that's painful. It's due to meningeal irritation. You can get Terson syndrome, which is basically a triad of bleeding points in the eye. And you may also get focal neurological signs. So if you think anatomically, the posterior communicating artery is very close to the oculomotor nerve. So it can lead to, an aneurysm in the location can lead to an oculomotor nerve palsy. Investigations that need doing. Basically, it's a CT head and a lumbar puncture. So with the CT head, I've already shown you an image of it, but it can show hyperdense collections of blood within the basal cisterns, sulci, gyri, etc. However, some patients may have a negative CT scan. Lumbar puncture needs to be done 12 hours post CT if the CT is negative. However, as I've mentioned earlier, if you've got evidence of increased intracranial pressure, don't do an LP. That's contraindicated. So 12 hours after, you're likely to see something called xanthochromia, which is basically yellow colour of the CSF, and that's due to the bilirubin. The normal CSF is basically like gin. It's very clear. So the term is gin clear actually for normal CSF, and you can see the difference between normal CSF and xanthochromic CSF. You may run into confusion with a bloody tap or a traumatic tap, but you won't get xanthochromia in a bloody tap. Xanthochromia is very, very specific for a subarach. And then you may also find an increased opening pressure. Normal opening pressure is between 5 to 15 centimeter H2O for CSF. And definitely need a referral to neurosurge. Follow-up investigations are basically angios, so this can take the form of CT angio or digital subtraction angio. CT angio on the left image here, digital on the right. And basically we're trying to find a causative pathology that would require treatment with either coiling, clipping, etc. of the aneurysm. Treatment is in concordance with whatever's causing it. So aneurysms within the brain are likely to rebleed, so they need intervention, hopefully within a day at least. Make sure to examine the neurological system thoroughly and repeatedly, looking at blood pressure, pupils, GCS, etc. Thinking whether you need CT head again. Maintaining that cerebral perfusion pressure is of paramount importance. You don't want it to be too high because that can cause damage as well, but you just need to maintain it at an adequate pressure to be perfusing the brain, okay? And we've touched on the angiograms to have a look at the aneurysms on imaging. And in terms of treatment for aneurysms, it tends to be done by coil the vast majority of the time, but some may require a craniotomy with clipping. And making sure whilst they need surgery, patient's BP is controlled, prevent straining, which could cause a rebleed of the aneurysm. A drug to be aware of when treating subarachnoid hemorrhages is nimodipine. Okay, nimodipine, it sounds very much like amlodipine as well, felodipine, which are basically antihypertensives, and nimodipine is pretty much the same. It's a calcium channel blocker, but it's more specific to brain vasculature here. And nimodipine reduces vasospasm essentially. and it prevents something called delayed ischemic neurovascular deficit. So it's very important to give nimodipine. Hydrocephalus, that collection of the enlargement of the ventricular spaces with CSF, etc., because of blood needs to be diverted through drainage or long-term via a shunt. And then we can think about stents and balloon remodeling as well. So, once you've treated someone, you think they're stable, there are chances that they can deteriorate. So you've got the general causes and the more specific causes. General causes can be respiratory, so lack of oxygen to the brain, hypoxia, urinary problems, cardiac, VTEs, thromboembolic causes, and electrolyte disturbances. Those specific to subarachs may be a rebleed, so this is actually the commonest cause of death within the first few days. Hydrocephalus, so it takes mainly two types: obstructing, where there's a dysfunction in the flow of CSF between the lateral ventricles to the third ventricle to the fourth ventricle, or it can be communicative. So this is basically a problem with CSF absorption at the arachnoid granulations. So you require, a drain to be put in. The term I mentioned earlier, the delayed ischemic neurological deficit, which is basically vasospasm, you prevent that by giving nimodipine, as I've mentioned earlier. Hyponatremia is common because of SIADH, so you need to fluid restrict the patient. Patient may undergo seizures, however, in some unfortunate cases, they may well die, often due to rebleed. So, sort of predictive factors in a subarach would be their conscious level, age of the patient, and the amount of blood seen on a CT head. Fine. Mortality. So mortality in subarachnoid hemorrhage, in terms of percentages, is listed here. So there's grading, basically, of the severity of the subarach. And as you can see, as you go down in severity with all these various signs, mortality starts to increase. So much so that if someone's in a coma, the likelihood of mortality is 100% there. And so just to recap on that CT image, CT here shows again a subarach with blood in the basal cisterns, the sylvian fissures and the interhemispheric fissure. And it's that typical distribution that you tend to see in most subarachnoid hemorrhages into the subarach space. Fine, so that's it really for subarachnoid hemorrhages. Now I'll move on to the third bit of our presentation. This is the shortest bit. So this is on CNS infections. There's actually loads and loads of CNS infections, and it's not really within the scope of this presentation to go through each one. However, the ones I am going through I've emboldened here and underlined. Meningitis, encephalitis, brain abscess, and neurocysticercosis. Some of the others I haven't included, but where you may want to have a look into depending on the module, so neurosyphilis under the sexual health, toxoplasmosis, and how that may need to be differentiated from a cerebral lymphoma in those with HIV. We've got all the HIV neuro complications, which would come under sexual health, things like progressive multifocal leukoencephalopathy caused by the JC virus. You've got things like discitis, which probably would come under the orthopedics part as well. So a lot of this is under the locomotor module of year 4, but I'll be covering the 4 ones that are boldened here, mainly meningitis and encephalitis, to be honest. Okay, so meningitis. Meningitis, is, as the name suggests, is an inflammation of the meninges, and the meninges form under the dura, arachnoid, and the pia mater, which we were talking about under the hemorrhages section. It is indeed a medical emergency. Causes in adults likely to be viral, but may also be bacterial, of which the major causes are pneumococcus and meningococcus as well. The problem, and also can be related to a fungus as well. So in terms of the difficulty with meningitis, particularly bacterial meningitis or meningococcal infection, is that they may even mimic a viral infection, so it can present quite non-specifically initially, at least. So the classical symptoms, especially in infants with bacterial meningitis, tends to develop actually quite late on, and often it's quite late to be thinking about meningitis at that stage. So symptoms actually do progress quite quickly and become quite severe as time progresses. So it's always worth keeping meningitis in your mind if a child is coming in and doesn't seem right to you. In terms of features, meningism, basically irritation of the meninges, can result in headache, photophobia, neck stiffness, Koenig sign, which I've mentioned, and Brzezinski's sign, which is when the neck is flexed, the hip and knee flexes in as a result. Some of the other features include fever, consciousness level reduction, seizures, a rash which would indicate septicemia, and nausea and vomiting. Complications would include sepsis and Waterhouse Friderichsen's, which is basically like a bleed into the adrenal glands. So the organisms that tend to cause it can be sort of split into the various age groups. So very young children, so neonate to 3 months, you're mainly thinking of GBS, so group B streptococcus, often from like an infection during delivery, E. coli and other gram-negative organisms, and listeria, which we need to cover with amoxicillin and ampicillin antibiotics, or ampicillin antibiotic. Listeria is also very common in the immunocompromised. Those between the ages of 3 months to 6 years of age have the classic causes, so meningococcus, pneumococcus, as well as Haemophilus influenzae. Those above 6 years of age, likelihood is meningococcus and pneumococcus, and those 60 years plus is the same as those above 6 years of age, but also with listeria added too. Investigations you want to be doing. So full blood count, so you're looking at basically a white cell count really. CRP for loads of infections it's an infective marker. Coagulation screen, because patients can often get disseminated intravascular coagulation. Doing a blood culture, especially if someone's septic. Polymerase chain reaction if you're thinking about any viral cause. Serum blood glucose, a blood gas as well, and also lumbar puncture. Once again, only if there's no signs of an increased intracranial pressure, which would be a contraindication for this investigation. So how to manage it, okay? So, So meningitis is a medical emergency, okay? So basics are your ABC management. You want to get them on oxygen. Make sure that they're not shocked. So fluid resuscitation may be in order. Definitely call for help early. It's definitely no point doing it as a one-man army. You need a whole team there. You may want to be calling pediatrics if you're dealing with a child that you suspect who has meningitis. Antibiotic of choice tends to be either cefotaxime or ceftriaxone. If your patient is not in hospital at that moment, say they're in a pre-hospital setting such as in the GP, giving them benzyl penicillin IM route can often be life-saving prior to their admission to hospital. Never delay their admission. IV dexamethasone has also been given, and this reduces the chances of neuro complications post meningitis. And if needs be, you may even need to refer to ITU for further management. Fine. So moving on to the antibiotic regimen. So the major one, as I've said, is cefotaxime and or ceftriaxone. There may be special circumstances, so the amoxicillin to cover for listeria here, and here specifically for listeria we use amoxicillin and gentamicin, the aminoglycoside antibiotic. So in terms of treating the patients with meningitis, we've covered that, but how about managing those, a patient's loved ones, etc., those in close contact with the patient? So we can give prophylaxis to those who have been exposed to respiratory secretions of the patient, and the antibiotic of choice is ciprofloxacin. The risk is highest within the first week, but the risk can persist up until nearly a month. And meningitis vaccination can often also be offered to close contacts if you test their serum for it, and you can give booster doses as well. This isn't really the case for pneumococcal meningitis. You don't really need prophylaxis. However, if there's a cluster of cases of pneumococcal meningitis, then the Health Protection Agency do have a protocol for offering, again, those contacts with antibiotic prophylaxis. So some of the neurological sequelae of meningitis, most common one is sensorineural hearing loss, which we can prevent actually by giving dexamethasone. The other neurological complications include epilepsy, paralysis, infective consequences such as sepsis or abscess, and finally intracranial pressure increase can cause brain herniation as well as hydrocephalus. So encephalitis now. So encephalitis features include fever, headache, so in that sense it's very similar to meningitis. However, they tend to have personality changes and seizures, which tends to be more specific actually for encephalitis. They may also have vomiting and other focal features such as aphasia. Herpes simplex virus tends to be the major cause in adults, and tends to affect the temporal as well as the inferior frontal lobes. How to investigate and manage encephalitis. So you're having a look at the CSF, analysing it for lymphocytes are likely to be present. Protein tends to be a bit high. Do a polymerase chain reaction specific for herpes virus. The CT scan may show temporal and inferior frontal lobe changes with hemorrhages. MRI actually tends to be more specific than CT. And you may see EEG, electroencephalogram, changes as well. Treatment is basically IV antiviral, specifically acyclovir, for that. And starting acyclovir promptly reduces mortality significantly. And so this is just an MRI of someone with herpes simplex virus encephalitis. You can see quite a lot of intensity in the white matter and the cortex within the medial temporal lobes and the insular cortex here. So just briefly on CSF analysis, this is actually quite an important slide to be aware of. So first of all, it's just giving some normal values. This was from Dr. Brecknell's lecture. So just some normal values to be aware of here. Always when we're measuring glucose in the CSF, we need to be aware of the serum glucose, and that's what we compare it to. Just some key points. So with bacterial sort of infection, the appearance tends to be turbid. You have high protein, low glucose because the bacteria are consuming the glucose, and the cells mainly seen on neutrophils. For viruses, appearance tends to be clear, not really turbid. Pressure is fine, protein is fine, glucose is fine, but the major abnormality is that you can find lymphocytes. In tuberculosis, it's similar to bacterial in the sense it's turbid in appearance. Pressure again is high, protein is very high, again low glucose due to the glucose consumption, and you get lymphocytes in tuberculosis, actually not neutrophils as you do in bacterial. So lymphocytes can occur in both viral and tuberculosis. Just briefly on subarachs, I've talked to you about xanthochromia and that bilirubin, which stains the CSF to a yellow colour. And with MS, oligoclonal bands is specific for that. Right, now just to briefly touch on the other two infections, brain abscess and neurocysticercosis. So brain abscess can be a result of a number of causes. So the sort of infection lead point can be from like the middle ear or sinuses, post-surgery or trauma, any other head injuries, okay, or can be seeding of endocarditis into the brain. Presenting symptoms will depend on where exactly in the brain the abscess is, really, and the mass effect that it's going to cause. But an increase in the intracranial pressure is actually quite common. Symptoms may include fever, headache, neurological signs. A swinging pyrexia is not really that common with brain abscesses, though. A CT head is definitely needed, and treatment is basically surgical with abscess being debrided, drained, essentially. And then finally on neurocysticercosis, this comes from pig tapeworms. Symptoms include changing consciousness, fever, seizures that can become generalized. You can identify personality changes and weakness as well. And there are some of the symptoms there for children, as they may be more irritable, a change in their mental state. They may also suffer seizures, may be disorientated, speech difficulties, weakness, as well as fever. Right, so this is the final bit now, cerebrovascular disease, okay, specifically strokes and TIAs. So I've covered, so far we've gone through traumatic brain injury, all the different types of hemorrhages there. We've talked about primary, secondary traumatic brain injuries as well, herniations. We then moved on to subarachnoid hemorrhages. We did a disease profile basically of subarachs and the sort of complications post-subarachnoid hemorrhage. And then we went on to CNS infections with regards to meningitis mainly, encephalitis, brain abscess, and neurocysticercosis. So as I said, final topic now, strokes and TIAs. So a brief introduction to stroke. It's a very important cause of morbidity and mortality, with a high number of UK patients suffering strokes every year. A UK-wide public health awareness campaign was FAST. This is quite a good way of thinking about some of the symptoms of stroke: face, arms, speech, and time, which I'm sure you've all heard of. So what a stroke is can often be termed a cerebrovascular accident, or CVA, and it sort of represents a disruption in the blood supply to the brain. And because your brain tissue is extremely metabolically active, it needs a lot of oxygen going through to it. Any disruption in the oxygen delivery to the brain can have dire consequences. There are two main types. You've got ischemic and hemorrhagic. Ischemic forms the vast majority, nearly 70 to 85% of the time. And though within ischemic you can have those that last more than a day and those which are under a day in duration, those tend to be known as TIAs, or transient ischemic attacks. So comparing ischemic and hemorrhagic strokes. Okay, so ischemic is a interruption that sort of blood flow to the brain, whereas hemorrhagic is like a bleed, which we've covered earlier. The proportion of strokes are slanted towards ischemic rather than hemorrhagic. Subtypes of ischemic, so it can either be thrombotics, which is basically a clot within the vessel leading to the brain, such as like the carotid artery, or maybe an embolism, so that can take the form of fat, air, amniotic fluid, bacteria, or most likely blood clot. Main one when you're thinking about a blood clot is really atrial fibrillation. The stasis of blood, often within the left atrial appendage, tends to cause formation of a clot, which then works its way down into the left ventricle and into the left side circulation and up into the carotid via the aorta. So that's why we give patients warfarin, essentially, to prevent that from happening. In terms of hemorrhagic, we have intracerebral hemorrhages, which, as I've covered earlier, is like a bleed within the brain, or subarach, which is a bleed in between the arachnoid and pia mater. And finally, with regards to the comparison of those two, the risk factors. So ischemic risk factors are your general cardiovascular risk, so age, smoking, high blood pressure, diabetes, high lipids, so that's basically like your metabolic syndrome, and also AF, which we've talked about already. Hemorrhagic, which we've touched on earlier in this presentation, but risk factors include older patients, high blood pressure, AV malformations, and anticoagulation therapy like warfarin. So signs and symptoms, okay? So strokes can actually appear different in different individuals, and that's because the stroke symptoms can depend on exactly where you have the pathology. So generally it's defined as a rapidly developing set of clinical signs with disturbances of cerebral function that last more than a day, which can often lead to death with no apparent cause other than that of a vascular origin. Okay, TIAs, as I've said, are symptoms and signs that tends to resolve within a day. So some of the general features you may find in a patient may be motor weakness, speech problems, swallowing problems, difficulties with vision, and also their balance. So if it's an infarct to do with the cerebral hemisphere, it's quite good to think about what each of the lobes of the brain does. And so basically, if you think about what a particular part of the brain does, then if you have an interruption of its blood supply, then you know what deficit you're going to have. So that may take the form of hemiplegia. So say for instance, that would more likely point towards a anterior cerebral artery stroke if it's the legs, or a middle cerebral artery stroke if it's the face and arms. Sensory loss, homonymous hemianopias, and dysphasias as well. Brainstem infarct is likely to lead to a quadriplegia and locked-in syndrome, which is basically when patients can see you, hear you, but they can't respond to you, and tends to be due to problem with the pons part of the brainstem. Lacunar infarcts, so this is caused by often due to hypertension actually, and damage to the small arteries leading off the middle cerebral artery, known as the lenticular striate artery. They supply very major parts of the brain, namely the basal ganglia, the internal capsule, the thalamus, and the pons, and can result in symptoms of pure sensory, pure motor, sensory motor stroke, or ataxic hemiparesis. So the major classification of strokes takes the form of the Oxford Stroke Classification, which is what I've listed here. So you can split the classification types into anterior circulation and posterior circulation. So anterior circulation in itself is split up into total anterior circulation infarcts and partial anterior circulation infarcts. So you need to consider the three symptoms listed there. So unilateral hemiparesis or hemisensory loss of the face, arm and leg, a homonymous hemianopia, or a higher cognitive dysfunction such as dysphasia. If you were to have trouble with all three of them, that would be a total anterior circulation infarct, whereas if you were to get two of the three, that would be a partial anterior circulation infarct. So it's very important to put those to your mind. In terms of lacunar infarcts, I've touched on that earlier, but that's pure sensory, pure motor, sensory motor problems, and ataxic hemiparesis. So any one of those. And that tends to be due to ischemia of the thalamus, basal ganglia, and internal capsule caused by the lenticular striate arteries causing problems. Posterior circulation infarcts, or otherwise known as POCI, involves the vertebrobasilar arteries, and that causes problem with the cerebellum, brainstem, leads to loss of consciousness, and causes an isolated homonymous hemianopia as well. So differentiating between ischemic and hemorrhagic strokes. So in terms of symptoms, it's quite difficult initially to differentiate between hemorrhagic and ischemic, but those who've suffered hemorrhages are more likely to have a decrease in their consciousness level, may have headache, nausea and vomiting, as well as seizures. Okay, just bear with me 1 second. Okay, fine. Blood supply to the brain. So this is quite an important slide to be aware of just anatomically. So in terms of blood supply, so this is if you basically cut the brain from you cut the brain in half, and this diagram represents where each of the arteries are supplying, and you can think about that in terms of, if you had disruption of those arteries, what consequences that would cause depending on where it is in the brain they supply. And this is the circle of Willis here, demonstrating again the various arteries leading to the sort of posterior circulation of the brain, as well as the brainstem circulation. Okay, fine. So just a brief summary then of just thinking about what those arteries do and what consequences they would lead to if they were to have an interruption in their blood supply. So anterior cerebral artery would cause a hemiparesis and sensory loss of the legs. Middle cerebral artery would cause a hemiparesis and sensory loss mainly of the arms. May also cause problems to the face as well. And can cause a homonymous hemianopia, as well as aphasia. So we're thinking really about the TACI symptoms, the total anterior circulation infarct symptoms. Posterior cerebral artery can also cause a contralateral homonymous hemianopia with macular sparing. The reason why it's macular sparing is because you have dual circulation from the middle cerebral artery as well, and you can have visual agnosia. Retinal or ophthalmic artery interruption can cause amaurosis fugax, and patients with TIAs often can report some sort of blackening of vision, and they go blank in that eye for a short period of time. And finally, locked-in syndrome due to basilar artery problems, and it causes a problem with the pons essentially. And I've talked already about what locked-in syndrome is. Just a few special types of strokes that we may not have come across previously. Weber's syndrome is basically a problem with the posterior cerebral artery circulation supplying the midbrain that causes a oculomotor nerve palsy, as well as a weakness of the upper and lower extremities contralaterally. Wallenberg syndrome, caused by problem with the pica, causes pain and temperature loss of the face ipsilaterally with dysphagia, cranial nerve palsy, causing a Horner's syndrome. Contralaterally, there's limb and torso pain and temperature loss with ataxia and nystagmus. And finally here, lateral pontine syndrome caused by AICA or AICA artery is actually quite similar to the Wallenberg syndrome, but it causes an ipsilateral facial paralysis as well as deafness. Okay, so now moving on to assessment of someone with stroke. So you may have heard of the Rosier sort of system, and this basically sort of goes through the major symptoms that someone can present with if they're having a stroke. If their score is above 0, they're likely to have a stroke, essentially, and would require a non-contrast CT head. Investigations, as I've mentioned, is the first line is a non-contrast CT head. In some cases, you may want to do an MRI. But bleeds are best seen on a CT scan initially, because bleeds can often look similar to just brain tissue on an MRI in the acute stages, essentially. And the main reason why we're doing a CT head is basically we're trying to exclude a bleed, which would influence our management as to whether we give the patient thrombolysis. So just a brief overview initially before I go into a bit more detail on how to manage ischemic strokes. So you do your non-contrast CT head to differentiate between an ischemic or hemorrhagic stroke. If it were to be ischemic and provided criteria are met, you would offer the patient thrombolysis if they present within 4.5 hours of symptoms, essentially. There are contraindications to thrombolysis. Once you've excluded the hemorrhagic stroke, you need to be giving the patient aspirin 300 milligrams per orally as soon as possible. So just a bit about it in depth now. So things to monitor in the patient, okay, so would be their blood glucose, hydration status, their SATs and temperature. Don't lower the blood pressure acutely, because that unless they've got things like hypertensive encephalopathy, but lowering it acutely can often be quite bad, because there's often problems with the autoregulation of the brain and the blood pressure at when someone has a stroke. Aspirin 300 milligrams tends to be given orally once you've excluded the hemorrhagic stroke using the non-contrast CT. With regards to atrial fibrillation, don't start anticoagulants until brain imaging has actually definitively excluded your hemorrhage, and often not given until 14 days have passed from the onset of an ischemic stroke. Cholesterol lowering is also beneficial, but just wait until 48 hours have passed, because there has been evidence that giving a statin can often increase the chance of a hemorrhagic stroke in the acute stages. Okay, so yeah. In terms of thrombolysis, I've mentioned you're giving it if the patient has come in with symptoms within 4.5 hours, within the 4.5 hour window, and you've definitively excluded a bleed. And I've listed here some of the contraindications, absolute as well as relative, for thrombolysis, which you can read in your own time. A new method being used nowadays is thrombectomy. And thrombectomy is performed within 6 hours of symptoms onset, along with thrombolysis. To those who've had an acute ischemic stroke and those with confirmed occlusion of the anterior circulation, which has been demonstrated by an angiogram. You can also offer thrombectomy to those who are last known to be well between 6 to 24 hours previously, those who wake up with symptoms of a stroke, with confirmed blockage of the proximal anterior circulation, again demonstrated by angiogram, and you have the possibility of saving brain tissue, which is demonstrated by CT perfusion or MRI imaging. And finally, consider thrombectomy along with thrombolysis as soon as possible for those last known to be well up to 24 hours previously, again including wake-up strokes, For those who have acute ischemic stroke with an occlusion of your proximal posterior circulation, i.e. basilar or posterior cerebral artery circulation, again demonstrated by angiography, and with the possibility of salvaging brain tissue with evidence on CT or MRI. So, once you've treated the patient with all the various things that we've mentioned, aspirin, thrombolysis, thrombectomy, etc., we need to prevent a stroke from happening. And the evidence base is behind clopidogrel at the moment, clopidogrel monotherapy, and they'd continue this for life. If the patient does not tolerate clopidogrel, then you can put them on a regimen of aspirin and a dipyridamole. Dipyridamole aims to increase the cyclic AMP levels and reduces thromboxane A2 levels. But as I said, it's only for those who can't tolerate clopidogrel. If you can't tolerate aspirin as well as clopidogrel, then you'll just put on dipyridamole monotherapy post-stroke. Another thing to be aware of is carotid endarterectomy, and it's recommended in those who've suffered a stroke or transient ischemic attack in the carotid territory and aren't severely disabled. In Europe, we use a stenosis of more than 70% for an indication for an endarterectomy. Hemorrhagic stroke we've sort of covered earlier under the sort of traumatic brain injury slides and the subarach slides. But basically, if you identify a hemorrhagic stroke, you want to be getting a neurosurgical opinion on it for further management. But unfortunately, the vast majority aren't suitable for surgical management, so it's often just supportive, really. And stopping anticoagulants like warfarin and antithrombotic therapies will minimize any further bleeding for that. Right, and final bit now of my presentation is basically transient ischemic attacks, or often known as a mini stroke. In the past, transient ischemic attacks, the definition was time-based, so those that last less than 24 hours. Now, however, this has changed to a more tissue-based definition, and it's a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without evidence of acute infarction. Assessment and referral. So you may have been taught in the past about the ABCD2 criteria. So, age more than 60, BP more than 140/90, clinical features of hemispheresis scoring 2 points, speech alone problems scoring 1 point, diabetes scoring a point, duration of symptoms, those that last more than an hour for 2 points, and those between 10 to 59 minutes for 1 point. All of that is old. Okay, NICE no longer recommend that. So instead, they are suggesting giving immediate antithrombotic therapy of aspirin 300 milligrams, unless the patient has a bleeding disorder or is already taking anticoagulant. Patient is already taking low-dose aspirin already, so in which case just continue the aspirin and just ask them to be reviewed by specialist. And third reason why you'd not give the aspirin would be if it's contraindicated. So these are the causes to refer someone. So if they've had more than one TIA or have had a suspected cardioembolic source or severe carotid stenosis, you need to discuss the need for admission or observation with a stroke physician. If the patient has had a suspected TIA in the past 7 days, they need to be seen by a specialist within 24 hours. If the patient has had a suspected TIA which occurred, a week, more than a week ago, they need to be seen by a specialist within 7 days. And make sure the person doesn't drive until they've been seen by a specialist stroke physician. Those who've had a stroke or TIA may not need to inform the driving and vehicle licensing authority, but they will need to not drive for a month for that. Further management. So it's actually quite similar to stroke in that sense. So the antithrombotic therapy is clopidogrel, which is given for patients post-stroke or post-TIA. And then, like with stroke, if you can't tolerate clopidogrel, you give aspirin and dipyridamole. And with carotid endarterectomies, same criteria is used again. So if the carotid stenosis is above 70%, then consider endarterectomy. But it's the procedure is very skill dependent. So that's it pretty much for my presentation. Apologies, it was quite a long presentation. Thanks very much for listening. So we've covered today 4 major topics. We've talked about traumatic brain injury. We've talked about primary, secondary traumatic brain injuries. I've talked about the GCS scale. We've talked also briefly about the various types of hematomas and hemorrhages in the brain. We then moved on to subarachnoid hemorrhages. We talked about the 4 CNS infections there: meningitis mainly, encephalitis, brain abscess and neurocysticosis. And then finally we finished with quite a lot of information on strokes and then briefly on TIAs. So that's it from me. Thanks very much for tuning into this presentation. I hope it's been informative. Good luck with your exam preparation and revision. Thank you very much.